Okay, good morning, everyone, and welcome to today's CME. My name is Samara Johnson. I'm a level 6 medical student at the University of Nairobi, and I'll be your moderator for today. I hope you can hear me. If someone could just react, just to ensure that you can hear me. I hope I'm audible. Hello?
Yes, you are.
Okay, thank you so much. So, before I even start CME, I just want to introduce or talk about what XYZEZ is about. So XYZEZ Med is a vibrant community of medical students from multiple universities united by the mission to enhance medical education in Kenya. So this initiative was driven by the need to create accessible, locally relevant, and tailored resources that directly address the country's unique healthcare challenges. So the current medical education system in Kenya frequently depends on foreign resources that may not always align with local context. And this gap may leave healthcare professionals less prepared and contributes to limited public awareness regarding various medical conditions. So XYZEZ Med is bridging this divide by developing a wide range of readily accessible educational materials, including relatable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and many others. So one such initiative is the CME series, designed to promote peer-to-peer learning, as it's often our peers who can break down complex concepts into more understandable terms. So this month being the Diabetes Awareness Month, today's CME is going to focus on the topic of diabetes. And it's also a milestone for us because this is our 10th CME. So it's very exciting for us. And yes, our topic today is on diabetes, and our speaker is Dr. Feizal Barasa. He's a recent graduate from the University of Nairobi, an entrepreneur and the founder of the MediCentials Supplies. He's very passionate about surgery, and in his free time, he loves to play and watch football, painting, and giving back to society. So without further ado, I'd just like to invite Dr. Feizal Barasa to take us through this topic. And I thank you.
Thank you so much for the introduction. I hope I'm audible. Good morning, guys.
Good morning. Yes, you are.
Yes, thank you. Can you all see my screen?
Yes, we can, but it's not on SlideShare yet. Now it is.
Again, good morning, everyone. From the introduction, my name is Dr. Feizal Barasa, and I'm quite excited to be able to tackle this topic with you guys today on diabetes. It's quite a broad topic, and it's a topic in which back when I was in med school, at least now I can say that, but when I was in med school, it kind of felt a bit complex how it was being broken down. So I've tried my best to break it down in a way that will be very simple and understandable to everyone to follow. It's quite a big topic, but I'm hoping that by the end of the presentation, you'll be living better than the way you came in. So if I start. So these are my objectives of the day. I want us to be able to define diabetes. I want us to state the types of diabetes. I want us now to go in specific into type 2 diabetes so we can expound on the etiology of type 2 diabetes. I want us to be able to discuss the pathophysiology of type 2 diabetes. I want us to be able to explain the clinical presentation, state the investigations. We can expound on the diagnostic modality. We state the complications, and then we can have a brief discussion on its management. So, definition. So, diabetes mellitus is a chronic metabolic disorder characterized by sustained elevated blood glucose, hyperglycemia, resulting from defects in insulin secretion, action, or both. What are the types of diabetes. So type 1 diabetes is an autoimmune destruction of pancreatic beta cells causing absolute insulin deficiency. Type 2, it's a progressive loss of insulin secretion by beta cells with subsequent insulin insensitivity. So point to note, type 1 is an absolute insulin deficiency, meaning one will need insulin supplementation for life, while type 2, it's a progressive loss of insulin sensitivity. The other type is gestational, so it's diagnosed from week 13 plus in a previously non-diabetic woman. Key point, the woman must be non-diabetic. If she was diabetic, it won't be gestational. She'll fall either under type 1 or type 2. We now have the other smaller types, so maturity onset diabetes of the young, pancreaticogenic DM, endocrinopathies, drug-induced, and infections. But of note, just need to know that the most important ones to know, it's type 1, type 2, and the gestational one. So now let's go to the etiology. So what are the risk factors for type 2 diabetes? So one of the strongest links is if you have a diabetic first degree relative. 2, if you're overweight and obese. 3, if you're taking a high fat diet. 4, if you have history of gestational diabetes, once you've given birth, you can now progress to now having this type 2 diabetes. 5, if you have cardiovascular disease and the risk factors associated with cardiovascular disease. 6, if you're hypertensive. 7, male gender. Oh no. 8, metabolic syndrome. So what's the pathophysiology of type 2 diabetes? So the pancreas produces insulin through beta cells of islets of Langerhans. So this insulin is produced as pre-proinsulin. So pre-proinsulin will be changed to proinsulin, and then the proinsulin will be further cleaved to produce insulin. So insulin has two chains, A and B, which will be in insulin, and the C peptides which will have been cleaved out. So this C peptide is actually quite important, as we'll come to see that in some ways of measuring our insulin action in the body, we can actually measure this C peptide. So what is insulin? Insulin is an anabolic hormone responsible for carbohydrate metabolism, protein metabolism, lipid metabolism, electrolyte regulation through intracellular potassium accumulation. So now, how does this type 2 diabetes come by? As we've said, it is progressive insulin insensitivity. So how does this resistance come by? So we have a number of ways that can come by. So one, if someone, as we had said, one of the risk factors is overweight and being obese. Yeah, a BMI of more than 25. So this central obesity, what happens? Central obesity will lead to increased levels of free fatty acids. So these increased levels of free fatty acids will cause impaired insulin-dependent glucose uptake into the hepatocytes, myocytes, and adipocytes. So if we are not taking in the glucose into the hepatocytes, myocytes, and adipocytes, what does that mean? It means that the glucose is being left in the blood. If it's left in the blood, what does that mean? We're getting hyperglycemia. Way number 2 is now the increased serine kinase activity in fat and skeletal muscles cells will lead to decreased expression of GLUT4 channels. These GLUT4 channels are actually needed to be able to take in the glucose into the fat cells and the skeletal skeletal cells, muscle cells. So if the GLUT4 channels are decreased, it means that you're going to be decreased cellular glucose uptake. The other way that this can happen is pancreatic beta cell dysfunction will cause the accumulation of proamylin in the pancreas. So if you have this accumulation, you're going to have decreased endogenous insulin production. So I have a small video just showing us the insulin production and mechanism of action. See my screen on the video.
Yes.
So sorry, please take note that there are small explanations at the bottom of the video. You can be following them as the video is playing.
Dr. Baraza, is there audio on this video? Because we're just seeing, we can't hear.
There's no audio, but
Okay.
there are subtitles. Are you able to see the subtitles?
No. Okay, on my end, I can't see.
Okay, let me sort that. The subtitles now visible.
Um,
Pancreas, can everyone see that?
I can see endocrine pancreas here.
Yes, okay. Thank you. So I hope from the video you've been just be able to see through an artistic impression just how insulin is produced and how it moves from pre-pro to pro-insulin to now insulin after the cleavage and release of the C-peptides, how zinc is used in the hexamization and how it's released and how it's going to act on the GLUT4, what's going to the metabolic effect of now allowing glucose to be stored in our skeletal into our adipocytes and hence causing the glucose to move from the blood into storage. So we can go back to the presentation. just now another summary, an image summary. So what happens is we have environmental factors. So we have environmental factors that affect us. So for example, obesity. So this obesity will lead to an insulin resistance. So if there's insulin is resistance, we are going to have, of course, as we've been saying this whole time, decreased glucose uptake. The other thing is genetic predisposition. We have said that the number one thing that can predispose you to having diabetes is having diabetes in a first degree relative. So what will the genetic predisposition do at the pancreas? We're going to have deranged insulin release, which is going to, of course, cause decreased glucose uptake. Again, it can also lead to increased hepatic glucose output because the liver, because there's a derangement, the liver is tricked to think that there's no enough glucose in the blood. So through processes like gluconeogenesis, glycolysis, we break down and we release more glucose into the blood. So what is going to happen? All of these are going to cause hyperglycemia. The sustained hyperglycemia is now what gives us type 2 diabetes. What is the clinical? So next thing, we can now go into the clinical presentation. So clinical presentation, we have symptoms, of course, symptoms and signs. I'm sure everyone is aware of the differences. So symptoms is what the patient comes into the hospital to tell you that I'm complaining of this and this. And signs is what you as a clinician are supposed to pick it out. So the symptoms, most common symptoms, this person will come in complaining of polyuria, polydipsia, polyphagia. Those three are the main complaints. Other complaints can be this person is complaining of unexplained weight loss, blurred vision, fatigue, pruritus, poor wound healing, calf cramps, and recurrent infections. For the signs, you are supposed, as the clinician, are supposed to be able to pick up when someone is having Kussmaul respiration. You're supposed to be able to pick out when someone is in diabetic ketoacidosis. You're supposed to pick out when someone comes with hyposmolar hyperglycemic state, the HHS. You're supposed to pick up a diabetic foot. Through cranial nerve investigation, you're supposed to pick out blood vision. And again, through physical examination, you're supposed to pick out an oral or a vaginal thrush. So the next thing you want to do is someone has come. You have come with those, you have picked out the symptoms, you have picked out the signs. So the next thing is, what investigations do you want to do in order to ascertain that, yes, this is diabetes? So before that, we just don't test anyone. Everything usually has criterias. So what is the criteria for testing for diabetes or prediabetes in an asymptomatic adult? So one, testing should be considered in adults with who are overweight or obese. So the BMI cutoff is 25, but if you're dealing with an Asian, it's 23. Who has one or more of the following risk factors. One, first degree relative with diabetes. 2, history of cardiovascular disease. 3, hypertension. We define hypertension as more than 140 over 90 milligrams of mercury or on therapy for hypertension. 4, HDL cholesterol. So HDL is the good one. So if it's less than 0.9, that's a risk factor. Or triglycerides, that's the bad one if it's more than 2.82 millimoles per liter. Women with polycystic ovarian syndrome, people who have physical inactivity, and other clinical conditions associated with insulin resistance like severe obesity and acanthosis nigricans. So that's the number one criteria. Number two, people who have prediabetes, so HbA1c of more than 5.7, impaired glucose tolerance or impaired fasting glucose should be tested yearly. Women who are diagnosed with gestational diabetes, as we had said, it's very easy for someone to move from GDM to type 2 diabetes. She'll have a lifelong testing at least every 3 years. For all other patients, once someone has reached 35, you want to make sure that they are being tested regularly. So if results are normal, tested should be repeated at a minimum of 3-year intervals with consideration of more frequent testing depending on initial results and risk status. If someone has HIV, you want to be able to test them. And if someone has TB, these are the comorbidities that you want to catch early, you want to be able to test them. So what are the tests that you want to do? So we have hyperglycemic tests. Number one is the RBS. So this one is tested anytime. It's random. So anytime you can take an RBS. Number two, it's fasting plasma glucose. So this one you tell the patient to fast for 8 hours, then you test. Number three is the oral glucose tolerance test, the famous OGTT. So you want to give the patient 75 grams of glucose, then you want to test 2 hours post this. Then HbA1c, it will reflect glucose levels for the past 8 to 12 weeks. So what are the other additional tests you can do? Of course, you can do your basic metabolic panel. You can do islet auto-antibody testing. So this one will help you to rule out whether it's a type 1 or type 2. You can do a urinalysis and the C-peptide that I was telling you about, though it's not routinely done. So what are the diagnostic modalities of type 2 DM? So if someone has, so one, when will you say someone has DM? So RBS of more than 11.1 millimoles per liter in a patient with hyperglycemia symptoms. If this is not it, if someone is asymptomatic, we want two or more abnormal tests. So what are the cutoffs? So according to the current guidelines for management of diabetes released in 2024, we are moving away from IGT, IFG. We are now basically classifying patients as if someone is pre-diabetic or someone is already diabetic. So what are the cutoffs? So one, HbA1c of 5.7 to 6.4, that's pre-diabetes. If it's more than 6.5, that's diabetes. Fasting plasma glucose of 5.6 to 6.9, that's pre-diabetes. More than 7, that is diabetes. 2-hour plasma glucose during the 75 grams OGTT. If it's 7.8 to 11, that's pre-diabetes. If it's more than 11.1, that's diabetes. Then random plasma glucose, the only cutoff is for diabetes, more than 11.1. So this is the flow chart of, it's a flow chart of how you are supposed to approach your patient. So again, it's just now summarizing what I've just been saying. So you have two types of patients. It's either a patient who has come symptomatic or the patient who is asymptomatic. So as I've said, in the patient who is symptomatic, the only thing we need to do is check the RBS. So the patient, so we are here. I hope you can see my pointer. So the patient presents with symptoms and signs of diabetes, which are they, as we have said, polyphagia, polydipsia, polyuria, recurrent UTIs, and candida. This person also has infections, poor wound healing, peripheral neuropathy, and unexplained weight loss. So in someone who's already symptomatic, the one test you have to do is RBS. So if someone is more than 11.1, a diagnosis of type 2 diabetes is confirmed. But if it's less than 11.1, we'd want to reevaluate the patient or consider other diagnoses. We want to advise on lifestyle modification if the RBS is between 7.8 to 11, which means that this person is at a pre-diabetic stage. We want them to modify their lifestyle so that they do not cross over to diabetes. So that is in a symptomatic patient. So what happens if the patient is asymptomatic and you're suspecting that this person might have diabetes? As we've said, if someone is asymptomatic, the cutoff is we need 2 or more positive tests. So you do your random blood sugar. So if it's more than 11.1, so that's already one positive test. You do another one. So what's your second test? You want to do a fasting blood sugar. So FBS, you do it. If it's more than 7, diagnosis is confirmed. But if it's less than 7, we want to reassess after 4 weeks. And then you want to advise on a lifestyle modification if the blood sugar is between 6.1 to 6.9. Again, meaning this person is pre-diabetic. If you are done, so let's come back up. If you are done, it's less than 11.1, it means that that's not your diagnosis. No further workup is needed, but you want to advise for lifestyle modification if RBS is 7.8 to 11. I hope that's clear. So we can move on to the next thing. So what are the complications of type 2 diabetes? So I classify them into 3. So we can either be talking about acute complications, macrovascular complications, or microvascular complications. So the acute ones are some of the signs that I hope you remember that I was talking about. The signs as the clinician you need to be able to pick up that yes, this person is in shock. So is this person in HHS or is this person in DKA? The macrovascular complications you're looking at is coronary heart disease and peripheral arterial disease. The microvascular complications you're looking at is this person having diabetic nephropathy, diabetic retinopathy, diabetic neuropathy, or diabetic foot? So for diabetic foot, it basically falls under both macrovascular and microvascular because in microvascular, the diabetic foot might be caused by a diabetic neuropathy in terms of this person has a wound, but because of the neuropathy is not able to recognize that they do have the wound. Then in the macrovascular sense, if they have a peripheral arterial disease, it means that blood flow to that specific area it's not well enough. So these combining factors can end up giving you a diabetic foot. So now to the last thing. How do we manage type 2 diabetes? That's the big question. Yes, the person walked into your clinic. You were able to pick up the symptoms that you've said. There was maybe polydipsia, polyuria, polyphagia. The signs. Maybe this person was already in shock. There's Kussmaul. You're thinking there's DKA. You're thinking there's HHS. You are able to do your investigations, as you have said. If it's symptomatic, you're just being able to you just need to do the random blood sugar, and if it's more than 11.1, that's a direct diagnosis. But if the person is asymptomatic, you said you need at a minimum 2 tests. So you can do your random blood sugar more than 11, put them into fasting 8 hours, fasting blood sugar more than 7. You can now be able to diagnose them. Next thing is, during the management, you want to check out, is this person having any other complications, the acute ones? You need to make sure that, because some of the ways a person can present to the hospital is they're already in DKA or HHS. So you want to be able to pick that up. Number 2, macrovascular, coronary heart disease, peripheral arterial disease. Look them up. Microvascular, neuropathy, nephropathy. So actually looking for neuropathy, the nephropathy, and the retinopathy. Then again, I've said the diabetic foot falls in both of them. We look at it. So now the next thing you're asking yourself is, how do we manage this type 2 diabetes? So of course we now have two type of ways in which we can manage it. It's either non-pharmacological or we can manage it pharmacologically. So for the non-pharmacological, we are focusing on healthy eating. So the next slide is going to have a sample plate of what you want to advise your patient to be able to eat. So the next thing is exercise. So healthy eating, exercise. So in exercise, what comes of it? People living with type 2 diabetes should do 150 minutes of aerobic exercise with 50 to 70% of maximal heart rate per week with resistance training 3 times a week. So that's very important because, you always tell the patients exercise, exercise. But what is exercise? Unless you tell this person exactly what you expect of them, you just tell them, oh, exercise. Someone will think that, oh, okay, I walk from the stage of my matatu to home. Okay, that counts. No, you need to be very specific. They need to be doing at least 150 minutes. Their heart rate should increase 50 to 70%, and they should do some resistance training at least 3 times a week. So this is the photo I was telling you about, a healthy eating plate. This is unlike most people. I always make this joke with my family in terms of from the area I come, this plate is inverted in which half of it is usually starch, the other quarter is usually meat, and a very small portion is vegetables. So as you can see, that's very wrong. The majority of your plate should be vegetables. So this is what you want to tell your patient. The majority should be vegetables. They should have plenty of fruits. They need to do whole grains, and they need to do healthy protein. So for the more the veggies, the better. Again, this is very important. Potatoes and French fries are not vegetables. Very important. Next is fruits. Eat plenty of fruits of all colors. Next, you can do whole grains. Want to do a variety of whole grains. Then we want to limit refined grains like white rice and white bread. Then healthy protein. Want to do more fish, poultry, beans and nuts. Want to limit red meat and cheese. Of course, avoid bacon, cold cuts and other processed meats. For water, you want the person to drink enough water, tea or coffee with little or no sugar. Limit milk or dairy to only 1 to 2 servings a day and juice to just 1 small glass a day. Avoid sugary drinks. So now the important place we've all been waiting for. What is the pharmacological management? So you've tried the non-pharmacological, it's not working, or we are not really getting our targets. So you want to put them in medication. So the number one medication you usually start with, internationally known as a biguanide, metformin. What's the dose? 500 mg per oral twice daily. It's our first line. So unless otherwise. So what are the unless otherwise? So I wasn't really putting a lot on the slides because of time issues, but you put them on the metformin unless they have no problems with their kidneys. The next line is DPP4, the peptidyl peptidase 4 inhibitor. For example, is sitagliptin. So the dose is 100 milligrams per oral once daily. You can also give saxagliptin. We usually avoid this in heart failure. Next is the SGLT2 inhibitors. For example, empagliflozin. We give 10 mg per oral once daily. We consider it in CKD patients and people who are wanting weight loss, if weight loss is a target. GLP-1 receptor agonist, semaglutide, 3 milligrams per oral once daily. Relaglutide, 0.6 milligrams subcutaneous once daily. So we consider if the EGFR is less than 30 mL per minute, and it's beneficial if you want weight loss. Sulfonylureas, glimepiride, 1 to 2 milligrams per oral once daily. Important consideration, it increases the hypoglycemia risk. So that's something you need to be very considerate about because we are trying to remove them from hyperglycemia. But drugs like sulfonylureas can actually now do for us the opposite and take us into hypoglycemia. So we need to be careful about that. But the good thing about it, it's affordable. Thiazolonidiones, example, pioglitazone, 15 to 30 milligrams per oral once daily. We avoid in people with congestive heart failure. Also, it's affordable. So our last line is usually insulin. So the important consideration is if targets are not met despite adequate compliant treatment. That's very important. Adequate meaning you moved from monotherapy of metformin to dual therapy. You are combining metformin with something else. Compliant, there is supervised taking of these drugs. So sometimes you think the drugs is not working, but the problem is the patient is not taking the drugs. So before you escalate or change or do anything, you need to make sure that, okay, this patient is actually taking these drugs in the way that is supposed to be taken. So if the methods are not, if this is not bringing down your blood sugars, it means you need to go to injectables. So for insulin, it's either given as basal bolus or mixed. So we just had a small summary on how insulin is given. So we have different types of insulin. So our first type is ultra short acting. So insulin lispro, aspart, glucilin, sorry. We usually take it before a meal to cover the blood glucose elevation from eating. We usually combine it with a longer acting insulin. Its onset is 12 to 30 minutes, peaks within 3 hours, and lasts between 3 hours. Next one is short acting. It's the regular insulin. We take it 30 minutes before meal to cover blood glucose elevation from eating. We have to also use it with a longer acting insulin. Onset 30 minutes, peak in 5 hours, duration 4 to 24 hours. Intermediate acting, it's NPH, covers the blood glucose elevations when rapid acting insulin stop working. So we can use the intermediate with an ultra short or a short. That's what we've just said down there. Onset 1 to 2 hours. It peaks in 4 to 12 hours and it lasts 14 to 24 hours. Long acting, it's glargine, ultra lente insulin, and detemir. It's often combined when needed with rapid or short-acting insulin. It lowers blood glucose when rapid-acting insulin stops working, and it's taken once or twice a day. Onset 3 to 4 hours. There's no defined peak and duration lasts more than 24 hours. So there's the new one, a very ultra long acting. It's degludec. It's available as combined with short acting insulin, and it lower when the short acting stop working. Onset 30 to 90 minutes. It has no peak and it lasts more than 24 hours. So just to touch on it, I've said that now we have these different types. Okay. We've said that we can give them as basal bolus and mixed. But what is basal bolus? So basal bolus is basically, as we have said, we are trying to combine a short acting with a long acting, or we are combining a short acting with an intermediate acting. We have ratios. We want to give 60% it to be a short acting and 40% for it to be a long acting or an intermediate acting. Mixed, it usually comes as a premix, or you actually mix it in the hospital. It's usually a mixture of short acting and intermediate acting. We give 2/3 of the dose in the morning and 1/3 of the dose in the evening. So I think that's it. It was a very heavy topic. I've really tried to touch on everything that it's very important, and I hope it's been beneficial. Thank you so much for your time. And a quote that comes from the religion I practice: and whoever saves one life, it is as if it has saved the whole of humanity. Just to encourage people in these tough times, let's work to become better doctors that we all deserve. Thank you.
Thank you so much, Dr. Barasa. That was a really good presentation, and I'm sure everyone has learned quite a bit. I'm not sure if anyone has questions, but we are going to do the Kahoot session right now, and then we can maybe tackle any questions that come after that. So everyone can just maybe log in to kahoot.com. Let me see if I can get the link on. I'll post the link 1 second. Just to brush up on our short memory, short-term memory. But 1 second. Okay, so I'm posting the link on the chat, so you can just go there, and then I will project my screen, so you'll be able to see the pin that you need to put in. Just 1 second.
One other thing I wanted to add, Samara.
Yes, sorry.
To make it more interesting, as I said, I'm an entrepreneur. So from my business, the person who's going to get the highest marks of Kahoot will get some credit.
Okay, that should give you guys more incentive. Wow, thank you so much, Dr. Baraza. Now people will be more, involved in this Kahoot. 1 second, let me just share my screen. So I don't know if you want to join with your real names or your fake names, because now we have incentive for the top person. Here it is. Share. Think you're seeing my screen, right? Okay, that's the pin. So maybe you guys can just click on that link on the chat and then just put in this code or the pin 2146890. And we'll just give everyone like maybe 2 minutes to join. I see we're 28. Removing me and Dr. Baraza, that should be 26 people. Let's see how many join. The pin is on the screen, but it's 2146890. 2146890. Okay, we have 14 people. Maybe I give another minute or so. And for those who might not know how Kahoot works, obviously you need to choose the right answer to get points, but also speed matters. So if you have two people getting the right answer, the one who chose it faster gets more points than the one who was a bit slow. So you need to be quick but precise. So have to find a way to balance both of them. Right. 15, 16 people are here. I'll just give a few more seconds in case anyone else wants to join. 17. Okay, and so the questions will appear on my screen and the answers are color coded. So you just pick the color of the answer that you want to go with. So if your answer is in yellow, you go with yellow on your phone or your device. Okay, I think we can begin. So I'm starting the quiz. I hope you're ready. Thinking caps on. And we have officially begun. Okay, so majority of you got the right answer. What is the primary characteristic of type 2 diabetes? And it's insulin resistance. Well done. How do I go next? This thing. Sorry. 1 second. Yeah. So we have CM Punk leading with Yuli and Walooms behind, and KA and KKKKK. Interesting names, guys. Okay, so yeah, and also it's time. You have 20 seconds for each question. I forgot to mention that. So yeah, keep that in mind. Let's move on to the next question. Hey, wow, okay. People were listening in the session. So 16, majority of us again got it correct. Common risk factor is overweight or being obese. So let's see if any changes to the leaderboard. Yes, so we still have CM Punk in Yuli in the top two, and Anand has come to third place. That's a good jump. Welcome to this leaderboard. Balooms and KKKK closely behind. It's a tough competition. Okay, we have again majority have got the correct answer. This is classified as pre-diabetic. Let's see if there's any changes to the leaderboard. Okay, good. So CM Punk still leading with Yuli close behind and Anand. KKK, congrats. You're having I think the most number of streaks with 3 correct answers in a row. And KA is back up on the top 5. So let's move to the next question. Okay, I can see people are clearly listening in the session. Everyone got this correct. Metformin is the first line drug prescribed. So any changes to the leaderboard? None. So CM Punk still leading. Oh, Burrow has 4 correct answers in a row. Congratulations. You guys still have time. We have still more questions to catch up. So let's move on to the next question. Okay, so we have majority choosing the correct answer. 500 milligrams per oral, twice is the starting dose of metformin. Well done. Any changes to the leaderboard? Yes, we have YH coming to the top 5, but the top 4 still remain the same. And Rotich is the highest climber, 4 places up. That's a good jump. Let's move to the next question. Okay, well done. Everyone who's got this question correct. Your monitor using HbA1c. Any changes? Okay, Anand has moved to the top and second place. CM Punk still leading. KKK is having the highest answer streak of 6. Well done. So let's see if any more changes can happen in the next 4 questions. Okay, so over here we have a bit of divide in the answer, but the correct answer for the effect of insulin resistance in type 2 diabetes is increases blood glucose level due to reduced effectiveness of insulin. So let's see if this caused any changes in the scoreboard. Okay, Anand has dethroned our number 1 and come to the top with Yuli following her in second place, CM Punk at 3, KKK 4, and YH at 5. We also have 3 players at a streak of 4, so that's good. Let's finish strong. Okay, there was, I think, a divide between C and D, but I think the only thing that was a difference was thrice a week or twice a week. And I believe in the CME teaching, it was thrice a week, which is the right answer. But let's see if this causes any change to the scoreboard. Okay, CM Punk is now at 2, Anand still leading with the highest, with a correct answer streak of 8, Yuli at 3. 1 to 3 has joined the top 5. Welcome to the top 5. 1 to 3. Let's see, let's finish strong. 2 more questions, guys. Okay, majority have got this correct. The answer most effective is increased physical activity. Let's see if this changes anything on the scoreboard. Nope, we still have the same top 5. KA is the highest climber. Well done. Seems like you had answered the question very quickly. And let's do the last one, last question. Okay, so we've had a divide between the answers for A and B. So the correct answer for what is the main reason why individuals with type 2 diabetes are at increased risk of CVS diseases are the insulin resistance increases inflammation and promotes atherosclerosis. So that was our last question, and we'll get to see who the top three are. The third place, let's give it up for Yuli. Let's clap for her. I mean, or him. I don't know who you are. At second place is CM Punk. Let's clap for them. And top is congratulations, Anan. Well done. It's well done to all of you who participated. Um, you've all done a good job. If you've seen, majority of you got all the answers correct. So it's just about timing. 1 second. Stop sharing. So I think Dr. Baraza, you've seen that you've actually whatever you've said has been has actually entered people's brain and they've understood because majority answers people choose were correct. Oh wait, sorry, I forgot. So we would like to have the winners say something. So number 3 was Yuli, if I'm not wrong. So would you like to say something? Okay, silence. Some number 2, I think, was CM Punk. Would you like to introduce yourself and say something? No? People are shy? Okay. Maybe Anan, would you like to just unmute, introduce yourself, and just say something?
Hi, my name is Mariam. I think the session was very informative. Good job.
Perfect. And I think Dr. Baraza has a prize for you waiting. So I don't know how that's going to reach you. There's going to be some kind of agreement. I'm not sure. Uh, yeah.
Yes, she can text me. I'll put my number in the chat box.
All right. Perfect.
Okay.
Yes. Any questions for Dr. Baraza on today's CME on diabetes? Any clarifications you wanted? Or even from maybe something in the Kahoot quiz that you saw, maybe you didn't understand and you want a clarification for why that was the answer? Please go ahead. Either you can unmute or you can put it on the chat. I'll wait for maybe a minute on the chat. If there's no questions, I think we can call it a day, but we can give everyone a minute in case there's any questions.
Hello.
Yes.
Yeah, I have a question. Okay, thank you, Doc, for the presentation. It was really profound. Yeah, my question is about the diet. So is there still a role of, in terms of quantity, is there like in terms of the quantity of food that the patient are supposed to take? And also, initially they used to advise on brown bread, brown rice for the diet. Are they still playing a role when it comes to the diabetic diet? So that's my first question. The second question is about insulin, especially mixed. I don't know whether this lecture, okay, this presentation, you was, would you mind like digging into detail in terms of how do we give the mixed and how do you calculate? Yeah.
Okay, thank you for the questions. I'll start with the first one on the diet. Let me just share that screen again. Oh, yes. So for your question one, is there a role for the amount? One, it's more of proportions than just eat this amount, because again, the goal is you don't want to leave this person hungry. Yeah. One of the worst things about diabetes is the fact that they cannot be able to store their glucose, means that their hunger episodes are usually quite bad. That's one. And two, they are on hyperglycemic agents, meaning if you don't eat enough, it means that these people could easily get into hypoglycemia. So one, these patients should be able to eat enough. The question now is, what is the proportion of what they're eating? In which I presented the healthy eating plate in terms of whatever they are eating, majority should be vegetables, almost going to half of the plate should be vegetables, and the rest should be fruits. Whole grains should form a very small part, and a quarter of it should be healthy proteins. In terms of the whole grains, you asked about brown rice, white rice. The suggestion is, according to the guidelines, the 2024 guidelines, the patient needs to eat a variety of whole grains. So, for example, whole wheat bread, whole grain pasta, and brown rice. So that the your question on if brown rice is still acceptable, that's there. We also want to limit refined grains. So things like white rice and white bread, we want to limit them. The thing is limit, don't stop, because at the end of the day, we want the quality of life to still be there. So limit, but don't stop. You tell the patient, I want you, when you are choosing your whole grains, it should be more of the whole grains like brown rice, whole grain pasta, whole wheat bread. But if you are doing the refined grains like white rice and the white bread, should limit it. Your second question was on insulin. And yes, so when it comes to mixed, so as I was explaining, we usually have two common types of presentations on how we give insulin. We have the basal bolus and the mixed. So your question is on mixed. So what happens in mixed is, for the patient's insulin requirements are calculated according, and we usually escalate it. Okay, so according to the weight and according to the target that we want the patient to be able to receive that insulin. So we calculate and we say that maybe this patient needs 20 cc. We are at 20 cc of insulin per day. Okay, so what are we giving for this patient? We're giving mixed. So mixed, the good thing about mixed is most of them comes as a premix. Like commercially, it's already mixed. It's usually a mixture of a short acting, so that's the regular insulin, with an intermediate acting, that's NPH. So it's regular insulin plus NPH. Most times it's at a ratio of 1 for short acting to 2 of intermediate acting. So this premix is already there. So now what you're doing is you have your 20. Okay, so it's now the 20, you do 2 over 3 times 20. So that's like 40 divided by 3, something like that's, hey, math, 14, around 14. So you give around 40, you tell the patient to inject 14 cc in the morning. And then what's remaining, it's around 6. You tell them to inject 6 cc in the evening. Then you continue monitoring this patient whether this amount has been able to control the diabetes. So if not, the next time they're coming to the clinic, we want to escalate it up. So we'll escalate based on their weight and what they've been taking before. So let's say now you escalate it, you calculate it becomes 25. You do the same calculation. 2 over 3 times 25, give in the morning. 1 over 3 times 25, you give in the evening. I hope that question was answered.
Yes, thank you. And when you want to, let's say, for instance, I don't know whether does this one also apply? Because when you were in PIDS, there was a way in which we could adjust, let's say, for instance, okay, you've addressed the adherence, you've addressed the compliance and also the diet aspect of it, but still the sugars are still high. Despite that, we also apply, we use in pediatric, we used to give them there was that chart for the hyperglycemia, and then now from there we could adjust based on the there was a certain ratio. So does it also apply here? Suppose they still have percentage hyperglycemia, you've addressed the compliance, you've addressed the diet issues.
Yes. So if they, again, as I was saying, once you put them on a regimen, you want them to, every day you're giving them a book. In KNH, we usually just give them like a normal book. And in that book, we explain them to be able to record their fasting and their random blood sugars every other day. So once they come back to the clinic and you are seeing that your levels are not good enough, it means that, and as you've said, you've covered your compliance and whatnot, all that is okay. It means that this is not enough. So you want to escalate it. So if this person was at 25, you now adjust it to, let's say, 27, you adjust it to 30, like you increase it. And the other thing is you can actually switch the regimen. If you can see like Mixtard is not doing it for you, you can switch the patient from Mixtard to basal bolus, because basal bolus is quote unquote a bit much better, because in basal bolus we give the patient a long acting in the morning and 3 times of a short or an ultra short every time 30 minutes before meals. So you see that this one will cover you much better as compared to Mixtard. So if you're seeing Mixtard is not working, you switch them to basal bolus. The only reason we start with Mixtard is, again, as I've said, quality of life. For Mixtard, you only have to inject yourself twice in a day. But for basal bolus, you have to inject yourself 4 times in a day. So, but if Mixtard is not working, of course, now you'll have to move on to basal bolus.
Thank you.
You're welcome.
Okay, I think there are no more questions. So once again, thank you so much, Dr. Barasa, for the session. And thank you all for joining. So just want to remind you that you can find us XYZEZ Med on Instagram, I think other medias also, and also we're on WhatsApp. We have the community where you can get the quizzes, like whatever we're doing, the quizzes, the CMEs, and all of those links. So feel free to join. If you want to join the community, you can reach me or anyone else that you know that's part of the group, and we can help guide you through that. See you all next week and have a wonderful weekend. Bye.
Bye.